Welcome again, everyone. I hope you enjoyed the poster session. There was some really nice conversation and lots of people presenting really terrific posters. So thank you, everyone, for bringing your posters and bringing your enthusiasm. Once again, I'm Ashti Doobay-Persaud, and I co-direct the Center for Global Health Education with Dr. Bill Leonard. And at this point, we're going to be doing our 2 keynote lectures. So our first keynote speaker is Lisa Umphrey. And Dr. Umphrey is a U.S.-trained pediatrician and an assistant professor of pediatrics at the University of Colorado School of Medicine. And after completing her residency at the University of Wisconsin, she moved to rural eastern Uganda and worked with various small nonprofits to provide pediatric care and build pediatric capacity in the region. In 2013, she created Atlas International, Inc., a U.S.-based nonprofit to support global health partnerships between Ugandan and U.S. colleagues. In 2013, she joined Médecins Sans Frontières, Doctors Without Borders, and completed several field missions before taking a headquarters position with MSF France as pediatric advisor, overseeing pediatric and neonatal projects worldwide. She joined the faculty at the University of Colorado in 2021 to be closer to home, and she serves there as a pediatric hospitalist, the Global Health Fellowship Director, the Global Health Pathway Co-Director for Pediatric Residents, and co-directs multiple courses on global health, underserved populations, and pediatric care in disaster settings. So with that, welcome, Lisa. Thank you.
Thank you. The IT guy left too quick. Thank you for that introduction. Can you all hear me if I swing this way and stand right here? Is that fine? Okay. I've been instructed not to move. Can I just say, this day you guys have scheduled is so cool. I didn't realize it was like a whole conference with people from all over. This is just a lovely opportunity. And I'm really honored that I got invited to come be a part of it. So thank you so much for having me here. And you kind of heard my backstory, so I won't repeat any of that. But today I'm going to talk you through partnership-driven initiatives in global health education. And I'm going to take you on a journey with me through my career path, kind of from the start up until now, and talk to you about the ways that global health education played into each of those stages, what I learned, what I didn't do well, and maybe some lessons learned, hopefully, that you can walk away from with this. I wish I had conflicts of interest to disclose, but I have none, and all my photos are used with permission. So these are some of the learning objectives that we're going to cover. Hopefully you've seen these before. Maybe they'll show up in evaluation or something, but we'll come back to these. This is the outline that we're going to walk through for today. But before I get to that, who are you? Who are all of you? Give me a show of hands if you're a student, like a medical student, public health student, some other sort of student. Okay, just a few. How about residents, fellows? Just a few. And then everyone else is faculty, I guess. Global health groupies. Okay, awesome. And then one more show of hands. Who has not yet engaged in global health activities with local partners or abroad, but wants to? Okay. No pressure, just you. And then everybody else, I assume you've engaged in some sort of travel or partnership activity? Yeah. Okay, great. That will help me kind of know what I should talk about. So just a quick snapshot of what my background is. Again, a lot of this was in my intro, so I won't repeat, but I did my first global health experience as a resident, which I'll talk about. I ended up moving to Uganda. I switched to the humanitarian world for the better part of my career, and then I came back to academia right as the pandemic was hitting, which is a great time to switch careers. I really recommend that. It works well. Definition-wise, so when I talk about global health, I'm talking about addressing health inequalities. For me, that's what global health is, whether it's local or it's international. We are trying to get at things that aren't fair and aren't balanced, right? And then global health education, for me, is addressing those health inequities through learning and through teaching. So that is a part of everything that we do in every single setting. And I really consider myself a global health educator, probably above and beyond everything else that I do. So my journey in global health started where a lot of yours have or will start, and that was with a short-term experience in global health. And I went to this region, can you see my cursor? Yeah, of rural eastern Uganda, right along the border with Kenya. I had a friend in my program who had completed a rotation at this site. I had an elective, so I went. It wasn't a whole lot more complicated than that. This was a while back, so some of the rules and preparation weren't really in place yet. This region of Uganda is just like mind-blowingly beautiful. It's in the mountains, it's in a national park, high altitude, really rural, lots of farming, coffee is produced there. And I went and worked at a pediatric clinic, which was run by this organization that you see in the photo. And I saw all the things that you hear about, right, before you engage with global health or when you go for the first time. I saw all of the challenges all in this small pediatric clinic. I saw a few health workers to really high patient loads, big mismatch with the need and the people who could meet that need from a clinical perspective. I saw lots of task shifting, which was weird for me as a US provider. I saw nurses acting as clinicians. I saw people without formal backgrounds working in medical roles in clinics to fill the gaps, and that was quite new. I saw so many supply chain disruptions. You hear that care is practiced, in these sort of low resource constrained settings, but you don't always see the reasons behind that. So there would be disruptions and supplies coming from the Ministry of Health to get to this clinic or to get to this region. So frequently we just didn't have what was needed to care for the kids that were there. There was a pretty minimal focus on patient education or follow-up, understandably, because of these high patient to provider ratios. We had plus-minus medical record systems in the area. Most of the time, families would bring a small notebook for their kids, and the health worker would scribble their notes in the book, just a blank book, and the families would hang on to that. Really easy to lose, really easy to get those damaged. We had a lot of people that I worked with on that first trip who were suffering from disruptions in their salaries and stipends. Some folks had not been paid in a year. This may sound familiar to some of you who have worked in those areas or have had colleagues who work for the Ministry of Health. Saw so many weather and climate challenges. Parts of the villages where I was doing my rotation would be completely inaccessible because of floods, mudslides, weather. So people couldn't get to work, people couldn't get to clinics. And because of all these issues, we saw really high burden of severe and preventable diseases and really high under 5 and maternal mortality rates, as you would expect. So I had very limited supervision on this first international rotation. I had a physician who was supervising me, and he was an hour away in a district hospital, but he went ahead and signed off on my rotation, which I didn't know until I got there. So I did lots of shadowing of clinical care. I teamed up with the equivalent of the advanced practice providers, usually medical officers or clinical officers in the clinic. And I saw so many needs, just everywhere, so many needs. And because I was heavily in the euphoric phases of culture shock, I was like, oh, I can do something about this. I can help. I can do everything. And so for all of those challenges that I saw for the first time in this small clinic in Uganda, I was like, I got it, everybody, I got it. The answer is we just have to train. It's education. The answer is always education. I'll educate the ministry, I'll educate the patients, and just ridiculous. And everyone very kindly and very patiently was like, that's great, Dr. Lisa. Yes, we did think about that before. Thank you. Yes, we did try that before, but these are the 15 reasons why it didn't work. Or, yeah, another doctor who was here before said the same thing. Not to be deterred, I, still wanted to throw myself into some sort of educational initiative. This is me on that rotation, actually. You can see what 15 years of nonprofit work will do to you. But I was, happy. I was going to change the world. I was going to educate everyone. And I decided to spend my rotation time on making a community and a staff education curricula. Who in the room has done something like this? Yep, you go to a place and you're like, I want to fix something. I'm going to make a lecture. I'm going to make a curricula. We all do this, right? We don't know much about anything about the context sometimes, but we can maybe address an education gap, we think. So that's what I did, and my colleagues were like, yep, you just kind of go do that. I tried to link myself to supervisors in the region and actually get a sense for who was around and who I could work with. I had a sense then that I might want to go back and do some more work. And I also tried to network with regional health sites, just learn about what was in the region and what I, while I was there, and then the people I was working with could benefit from. So I ended up going back and forth between Uganda and the US lots during residency, probably much more than I could get away with now. And I would see a little bit more of the context with each trip, like a little more of the layer would come off, and I would start to see a little bit more about why maybe the solutions weren't so simple or what some of the challenges were. One thing that started to come out in this back and forth time was that I started to get an appreciation that, for better or worse, I could do things as a visiting doctor that sometimes even my colleagues who were in these areas for decades and more at a time couldn't do. I could literally cold call someone at the Ministry of Health and say, hey, I'm a visiting physician from America, can I have a meeting? And they'd be like, sure. And then my clinical officer who'd worked for 30 years in the same clinic couldn't necessarily get that meeting. So, that sucks, that's not good. There's a lot of issues there to discuss, but I did figure out that there were things I could maybe push for on behalf of my partners and colleagues to try to move things along. I also realized as I figured out who the supervisors were in this region, just how poor the doctor to patient ratio was. At the time, it's better now, but at the time I had 2 doctors in a city about 2 hours from me, 2 pediatricians in that city, 2 more pediatricians on another city in the opposite direction, 2 to 3 hours away, and then 1 general physician in the region who was technically my supervisor. And that was it. There weren't any other physicians. And there were lots of other people providing care, but that's a pretty awful ratio. So the key lessons from this phase of my education, about education, was that first we have to do no harm, even for education. You can do a lot of harm with education as a visitor. You can think you know the best things to talk about or what needs to be done. And you just need to recognize that you can actually derail things, derail programs, derail communication through poorly planned education. The solutions seem obvious. They aren't. If they were obvious, somebody would have addressed them by now. There are years and decades and sometimes centuries behind the challenges that you might see, and you are not the person who's going to be like, oh, that has an easy solution. That's just not you. And then the last lesson from this period was that you're not going to be the one who fixes everything, but if you shut up and just kind of listen and be respectful, you might get some valuable information from your colleagues and your hosts about what you might be able to help with. So moving on to the immersion phase. So I moved to Uganda, as you heard in the intro, to go be the pediatrician for and the medical director for one of these small nonprofits that I had rotated with. This is a picture of my dog waking up from a nap and realizing we are no longer in Colorado, and she's wondering what is happening. And that began 3 years of full-time work living in Uganda, and I had lots of false starts. The whole timing and the urgency that you feel when you're doing a short-term rotation and all the work that you want to do and what you want to talk about, that intensity does not translate to when you go and move somewhere and work full-time. It's a much different way of interacting with people. So I found myself suddenly as the teacher and as the host for residents and learners coming to work with me from the universities in the US, just like the type of learner I had been. And initially, I was really teaching to them. I was setting up rotation programs for them. I wanted to have a good experience for them that met their home institution requirements. And it wasn't necessarily blended in well with what was needed by the staff or the clinic. So that didn't work super well. I also did a lot of letting the visitors decide what they wanted to teach on. You know, we had people coming to do a rotation, sometimes faculty, they had expertise. And we'd say, okay, well, what do you want to talk about in the time that you're here? It was not directed to what the priorities were or the needs at that time for the clinic or the patients or the staff. I initially tried to focus pretty heavily on CME for staff, because remember, I was going to fix everything through teaching. And whereas the clinic staff and the teams I worked with could humor me for, a 3-4 week rotation over a month, be like, yes, you can teach us, yes, we'll stay after work, yes, we'll do these things. Again, that doesn't really fly on a sustained basis. So my teams, who were seeing sometimes hundreds of patients a day, were not interested in hanging out for another half an hour after work once a week to do CME sessions. So we had to kind of rethink that. Also, in terms of what I was teaching, the comfortable thing is to teach on what you know and to try to share knowledge that you understand well. That's fine, but again, that may not match what's needed or what's important at that current moment. And it also can be really tempting to teach on fun things. Like my thing was to do like a suturing clinic, like go get pig's legs from the local butcher, go teach suturing. Everybody loved it. The crazy like white lady with the pig's feet and sewing them up. Didn't matter. Like it was fun. Everybody liked it, but that wasn't really an important skill. So eventually, after a few months of my very patient colleagues being like, okay, bring it in, like let's do something else, we did end up finalizing a more structured and a more organic, I would say, rotation program where we were welcoming med students and residents from the States and sometimes from Europe as well. And they were really brought in as part of the clinic functioning. And their purpose was there to support what was needed as opposed to them coming for their own sort of, rotation experience. After we did some needs assessments with the community, we started working on some clinic and outreach models to provide better quality care and start to address some of the like health literacy and knowledge gaps that were actually important to the community. We came up with 4 curricula to that end that we're still using today. We have what we call a waiting room patient curricula where health workers at these rural clinics we'll just kind of do a series of rotating lectures to folks that are waiting in line, because sometimes the wait times can be a few hours, so you can get in a couple of talks, distract the kids. And then we had a few other curricula that you can see listed here. Around that time, this is when Helping Babies Breathe was coming out. Are you all familiar with that program? It's kind of a low resource constrained setting adaptation for newborn resuscitation, if you don't know what it is. But I and some of the health workers that were in my team, we started unrolling that training and doing a lot of regional work, especially with Train the Trainers as we went along, doing NRP adapted trainings for our higher capacity health centers in the region, and then doing some projects with pediatric exam skills. Those were all things that were wanted and actually asked for, so we put our energy and visitors' time and efforts into those. And then the other big sort of accomplishment, I would say, is that I really was able, with my partners, to strengthen the partnerships throughout the region. I don't know if you all have noticed this yet, but global health is all about trying to do tons of really expensive stuff with zero money and zero support often, although it seems like you have a pretty good deal here. I think they do it well at Northwestern. But working in global health is really about having meetings with people, meeting them, literally putting your cards on the table and saying, okay, I've got this and I do this. What do you have? Okay, cool, I can help with that. Can you help with this? Oh, I can't do this, but I've got colleagues at Northwestern who I met at this cool conference this month who might be able to help you with that. And you're really just reaching out and just trying to like hold hands and connect and broaden your networks to put the very minimal resources and support that we do have for global health into all the places that might need it. This is just a little snapshot of a lot of the partnerships that I developed by the end of my 3 years in Uganda. And we also started showcasing our work. We were like riding high, except when we printed our poster a little too big and had to cut it and pin it up there. And things were good. Except I was in Uganda for a long time, and I started to see a lot of the kind of darker and not so nice parts of global health work. Who has heard about this story or saw this in the news or maybe even saw the documentary? Quite a few people. So I have this on here just to remind myself of the sort of darker aspect of the work, but the summary is what's in the headline. Basically, it broke news that there was a young American with no medical training, or maybe she had a little, who was operating a malnutrition center in Uganda, and a bunch of children under that center's care died. And she was there when I was there, and she kept a blog, and I remember the people with whom I worked at that organization at the time would be like looking at her blog at night and be like, oh my gosh, like what's this lady doing? This is crazy. And the kickers for me were that this happens all the time. Like this was one case that broke news, but you see this all the time. Like I was aware of dozens of people who were behaving like this, and supposedly reputable organizations that were acting this way. And the final kicker was that the organization I was working with at the time, a US-based organization, who was operating services in Uganda, wanted to partner with her. And I was like, no, like, we can't do that. And this kind of just ushered in this like burnout-y, really kind of darker phase of my career, which I think we all go through at different phases depending on how you engage in global health work. What I found was there was lots of bad stuff happening, that it's there if you look for it. And sometimes you find yourself even complicit in those organizations without you knowing it. As I was moving from the different sites within Uganda, I would usually do a year contract, and then I'd go on to another site to sort of replicate some of the work. And as I visited some of the previous sites, we couldn't sustain a lot of the interventions that we had put in place. And not for lack of effort or energy or wanting to make it work, it just isn't always possible. Funding mechanisms dry up, the priorities between a head office and field teams mismatch, or in a lot of cases, I was like the little Energizer bunny working 18 hours a day trying to get stuff in place. Who can relate to that? Everybody. That's what we do in global health, right? But that's not sustainable. There's no way that that's ever going to make any sort of lasting change. I saw lots of corruption from up and down within organizations, up and down within government structures, lots of just not nice things. And at the end of the day, I was a pediatrician working for US-based nonprofits who were operating clinical projects in countries where they weren't based. And so there was only so far I could go. There was only so much advocacy I could do. And I just fully burned out, just completely burned out after these several years in Uganda. But among all those partnerships that I had made, there were 6 that were just wonderful. They're still my partners today, but at the time they were the ones that were coming out as, the grassroots organizations, the Ugandan-based clinical structures, maybe nonprofits, but ones who had been in the region for 30, 40 years with really strong track records. Like, they were good groups. I professionally had decided I was going to switch to Doctors Without Borders, but I wanted to know how I could continue to support our educational work and our collaborations. So the key lessons from this phase were just, again, this idea of doing no harm. Sometimes doing nothing truly is better than doing something, and that goes for education too. Again, if you can walk away with one idea from this talk, it's that you can do a lot of harm, and you can do a lot of harm through education. The goal is to listen, collaborate, and then teach, instead of showing up and being like, I can teach, and then I'll listen to see if that works. It's absolutely backwards from what we should be doing. And the last lesson is that no one person can sustain the energy needed to make a lasting change. You just can't. If there's going to be any sort of lasting change in a local community, in an international project, whatever it is, it's going to take a marathon amount of work of a lot of people just like chipping away over time. And that's the only way anything sustainable is going to work. So switching over to my next phase, back to this partnership thing. I started a US-based nonprofit. So I'll explain why that's not awful. So I realize it sounds very hypocritical, but what I did was I decided the only way I could really advocate for my partners was to set up the infrastructure to be able to do that in a legit way. I couldn't ask people to give me money to help fund like a PhD program in Uganda if I didn't have a nonprofit or a 501c3 designation. So in the end, I created Atlas International. But what we do is we partner with existing Ugandan organizations. That's all we do. There's no Atlas clinic or hospital or even Atlas projects. It's just, we are the people that just try to help what other people are doing. And we connect US organizations with Ugandan partners, and we facilitate international medical rotations. And the main things that we do, and almost all of this kind of circles around education, is we link faculty and institutions for collaborative education. We advocate really heavily for recognition of those Ugandan faculty at the US institution. So if somebody's serving as the site mentor or the site supervisor, they should probably be recognized by the home institution, right, and have some sort of adjunct status. Usually those appointments come with library access and resources and all the things that a lot of people on the other side of our partnerships can't always access. We try to provide technical resources to our partners to help them with their educational initiatives. And then we do all the work for vetting and matching anyone on the US side who wants to go to Uganda to work with the partners, so that by the time the people show up, they've been prepped, they're ready, and then we help coordinate from our side, and they can just take it from there. We also work pretty heavily with trying to improve bidirectionality within the partnerships. This is really hard. Your program here at Northwestern is one of the great examples of being able to bring learners from places like Tanzania to the States. It's really hard to do, and it's really hard to get institutional buy-in. So we do a lot of advocacy for that sort of stuff. We also advocate a lot for academic equity. As partnerships are getting set up and projects are getting put in place, we make sure things are in play to ensure appropriate publication strategies where everyone is represented and authorship rules are followed and IRBs are completed at each place. So we do a lot of that to just make sure the partnership activity happens well and ethically. And then we do boring stuff like gather donations and fundraise. I'm going to highlight quickly just one of my partners. My main clinical research and educational partner is the Mbali Clinical Research Institute, or MICRI, and it's a three-pronged organization that consists of a research unit, Busatema University, which is a health sciences center for medical students, public health students, nursing students, and all departments of residents and fellows as well. And then there's a referral hospital, a big center, like where many of you have visited or have come from, sounds like. And they are focused on infrastructure development, conducting research that's locally relevant to the region, capacity building of their own staff, and then trying to get people after they've been trained to stay in the region and to stay on faculty to continue teaching, and then networking. The people who run MICRI have been doing this for 30, 40 years. They have PhDs from all over the world and represent all kinds of specialties. They don't need me, some like visitor on their second year, PEDS Global Health rotation to come and be like, well, I think you could teach on. No, they don't need any of that. They just need help kind of dealing with those barriers and those challenges like what we went through in the first slide. And that's a little bit about what we tried to do in Atlas, is just help to get some of those barriers out of the way so everybody can partner and collaborate a little better and a little more smoothly. So key lessons from the partnership phase of my career in talk about education are that you rarely need to create anything from scratch. You need to support what already exists, and if you don't know what already exists, you've got a lot of work to do. If you find, after speaking with people and spending time in areas, that something does need to be created, you're going to create it together with partnerships in kind of a dyad. You also need to have very clear partnership expectations and communication to make sure that all of this happens well and transparently and honestly. I'm going to switch super briefly to just touch on my time with Doctors Without Borders, just to say that the global health education lessons and tips that I cover in the talk, they're all very different in MSF, but they're also completely the same. I was kind of excited to see when I started working with them. And I also included this just to sort of present you all with a menu of things that I've done. So if anything's interesting or something you want to know more about later, feel free to reach out and we can chat about it more. But for those who don't know, Doctors Without Borders, the real name is Médecins Sans Frontières, great accent before when you presented it, or MSF, and it's an international, independent, and neutral humanitarian organization. It delivers aid to people affected by armed conflict, epidemics, disasters, and exclusion from healthcare, irrespective of race, religion, gender, or political affiliation. And the third sort of unique element about MSF is that their field staff and their teams bear witness or speak out. So there's a lot of public education about what's actually happening within projects in terms of what they see with patients or diagnoses or issues coming in. The medical activities for MSF range from top to bottom, from huge advocacy initiatives down through providing primary care to kids or vaccination campaigns, and every single element of their care in their projects is heavy with education. You think of MSF and you think of, the cowboys going in to deal with emergencies, and that's true, but that's a teeny little part of it, and that's an emergency team. Most of the organization is dealing with chronic, smoldering, just situations that need a lot of education and capacity development, just like anything else. So this is a picture from my first mission. I was in Mali. I was the only pediatrician assigned to a 400-bed pediatric hospital for kids under 5 years old who were suffering from malnutrition and malaria outbreaks every year. And what I didn't know at the time was I had a team of 25 Malian physicians who worked with me, and then I had a team of, probably 100 other folks, nurses, and other staff. And a huge part of my job, and what it means to be a pediatrician in MSF, is that I had to provide education at the bedside, help the physicians who maybe were fresh out of training or who hadn't had a lot of experience with children in these settings figure out what to do. A lot of times, MSF is actually not a super well-received organization to work with right away because it tends to be less highly paid than some of the other bigger groups. So you get people straight out of training, not a lot of experience, and people may not stay for too long. I found out it was super important to fill in the knowledge gaps, again with education sessions that were directed at what the doctors wanted to learn and what was going to have an impact then, not on what I was necessarily comfortable teaching, and so I had to address that gap in myself. I did a lot of work with identifying organizational gaps in education, so maybe there was a protocol that was missing or there wasn't a guideline in place, and I try to push for those things to come about within MSF. And then one of the biggest things that's education related is just the advocacy, my goodness, for children. It never fails to amaze me that even in these huge, well-known, famous organizations, you still have to look at people and be like, kids are not little adults, babies are not little children, and really advocate for the special needs for medical care protocols and all of that, and that's a big part of the work. So education really goes big to small anywhere in any of these settings. I'll skip this part. This was just to say that I did a few field missions and then took a headquarters position. But my biggest and the crux of my work when I was the pediatric advisor for MSF France was addressing these gaps in pediatric knowledge. So a big thing that we did was create guidelines. So how you provide neonatal and pediatric care for patients in MSF settings with MSF's resources and the specific sort of team makeups that we had. We also had to do quite a bit with creating protocols for particular clinical needs. For example, in South Sudan, we had a huge cohort in one of the projects of about 50 kids with type 1 diabetes who would come to the hospital, get their insulin a couple times a day as an injection, go out, run around the community, eat who knows what, go into DKA, come in, get a tune-up, and then head back out. Not your usual management of DKA or type 1 diabetes, so we had to have a specific clinical protocol for them. The other thing that comes up a lot, and I speak about it here in this part of the talk, but this is relevant anywhere in global health, sometimes there's educational needs for which there's no evidence or there's no information to guide it. During one of the crises in Yemen, which is still ongoing, but when it was kind of rolling out, we had famine in Yemen, we had really high rates of a severe acute malnutrition, and a lot of the kids suffering from that would also get cholera. Now, we've got great clinical protocols for both of those scenarios, but not necessarily for kids with two things in that context in that particular part of Africa. So there was a big push to try to address a huge knowledge gap and then teach that information to people in a way that would impact a crisis or an acute setting. This is just saying that no matter where you are, even if it's in humanitarian world, it's bedside teaching, it's trying to link up the limited professional expertise with a team of people who don't have that professional expertise and need some help. And formal courses and train the trainings are what you do everywhere in the world. So the lessons from this phase are that the need for education doesn't stop in a disaster, and it may be even more important. And I really think that the educational collaboration is how emergency projects and emergency teams stay safe by having respectful education and communication with your teams, by providing culturally appropriate information to your patients, by having a feedback mechanism so that you can have two-way exchanges of information. This is how you stay safe and neutral and unbiased and just provide good care no matter what that care needs to look like. And then the last thing is that a big part of global health may be trying to come up with evidence or guidelines or education when things don't exist. So while I was finishing up with MSF, I had a kid, and she's really cute, and she's a really bad person to travel with, the worst. And so we were based in Australia, linked to MSF France. I was still doing some clinical work at home in the States to try to keep up my US work, and then I was doing field visits and missions. So we were literally just circling the globe. I include this to say that this was my segue back into academia, but also to make the point that your interaction with global health and global health education is not fixed. Like, it's going to change depending on where you are in your education and what your personal and family needs are, and that's okay. You're going to kind of go big and then go small and maybe back up, and you're going to engage with it if it's important to you in different ways throughout your career. The need's always there. So I'm from Colorado. In the time that I was outside of the States, the University of Colorado set up a really nice Center for Global Health, and I came on board as faculty. And as I said, it was right as the pandemic was starting. And so I was joining academia right as the pandemic was hitting. And there was sort of this interesting interplay with suddenly I had questions for which there were no answers in the literature. And don't judge me, it was literally the first time I was like, oh, that's what research is for. I get it. You need to know something, but there's nothing to guide you. So you're like, oh, I could answer that question. My partners and I, as the pandemic were hitting, were trying to figure out how could engaging virtually keep up a lot of our educational partnerships and keep things afloat, or totally change for like a new world if things were going to move more into the virtual realm. So we wanted to know, could virtual activities replace the usual global health education activities that we had within our partnerships? Could those activities address bidirectionality barriers that we'd always run into? I don't need to tell you, it almost always is that the visitors from high-income countries are visiting the partners in low to middle-income countries. There's very often not the same flow of resources or learners the other direction. And so we wondered, okay, could virtual engagement address some of that and actually help bring people together bidirectionally? We wanted to know, could virtual global health address global health education and partnership inequities, some of these imbalances that I've talked about and touched on. And again, there was little guidance in the literature. So one of the first projects that we worked on was through the Association for Pediatric Program Directors, APPD, and we did a qualitative study interviewing partners of US-based pediatric academics to see what the partners thought about the partnerships in the context of the pandemic. And in general, people were pretty positive about their experiences, but unsurprisingly, a lot of the decision-making that was happening during COVID about educational activities was unilateral and led by the US partners. US partners decided when learners came back from the sites when COVID was hitting. They decided what the priorities were. They decided that they wanted to engage virtually with shared activities to keep up the learning for their own learners, but weren't necessarily evaluating it in the other direction. There was lots of worry from the global health partner sites and hosts, worry about what would happen to partnerships after the pandemic. They were open to using virtual engagement to keep going, but had a lot of concerns about how that could happen. And they wanted better communication, more bilateral exchanges, all the things. So we dug in a little more with some follow-up studies to look into what people think around the world about virtual global health education. Concurrently, we were doing this project with some of your faculty here from the Center for Global Health on opinions of pediatric educators and how they were interacting with their partners and how their educational approaches were changing. Just going to summarize quickly from this slide. We got lots of information from a lot of different people around the world, and we had a lot of no-duh conclusions, they're not that surprising, but communication and activities were disrupted by the pandemic, surprise. But the biggest things were that funding breaches, access to professional support resources, things like that, all the ways that partners could still continue to do their educational work, they couldn't do, and that hit the low and middle income country partners much harder. This was just to show that, again, among the high income country members of our team, we were like, all right, cool, virtual education is going to fix everything, much like I said during my first rotation in Uganda. Clearly we go through cycles in our life where we keep wanting to do the same thing and fix everything. But from our data, again, unsurprisingly, we found that the high-income country partners just across the board, of course, had better access to all the connectivity things, all the infrastructural things, and all the access to device things that would let virtual education continue. And a lot had to be addressed. I got super interested in this point because, as I'm sure a lot of you know, if you, as let's say a US-based resident or faculty member or student wants to go for a 1-month rotation somewhere, by the time you do your flights, your lodging, your per diems, your transport, all the things, you're probably going to spend, multiple thousands of dollars to go visit a partner site, or vice versa if people come from partner sites here. If that money wasn't spent to bring those two groups together, how far could that go for building up some internet capacity or building up some infrastructure with some of our partners? So all of this just kind of started unlocking a lot of conversations about how we use our money and how we can best bring everybody to the table. I just was going to make a plug here in terms of academic equity, that a lot of journals now are allowing co-first and co-senior authorship, which you may already know about, but it's worth stating more and more now. If you're doing global health education work and you're trying to write about it to get academic credit for your work, you're going to end up with an author team that's enormous, but you can advocate for that if each of you is on a different member or a different side of a partnership, and each member sort of has a buddy on either side of the coin. We followed up this work with a systematic review and saw a lot of the same issues that we saw in the other studies, so I won't review that again. And more recently, we've been diving into the access and interest and equity considerations for these educational initiatives as we move forward and really try to dig into how virtual engagement can start to fix some of these problems that we're seeing. Just wanted to put a plug in here that if you all don't know about it, many of your faculty here at Northwestern were authors on this curricular kit called the Virtual Education Partnership and Curricular Kit. It's free online through the Sugar Prep curriculum and the Sugar Prep website, and it's sort of a summation of all the research that we've done over the last few years and talks about ways to engage and do education in a virtual sphere to make it more equal and fair. So quick lessons from this phase. A lot of times we have to dig deep to see what the barriers are, and again, the solutions that may seem simple aren't. We really need to insist that all voices are at the table for the planning and agenda setting for our educational initiatives. We don't have any excuse anymore with COVID and Zoom and all the internet ways that we can, how old am I, the internet ways that we can engage. There's no excuse for not engaging in a more fair, equitable way to get everybody at the table. And the last bit is that, we learned we have to seek opportunities to capacity build and build new knowledge together, because a lot of it isn't there. So best practices, again, going back to this definition, the education is really about hitting the inequities through learning and teaching, right? And this is your own education, your partner's education, that two-way exchange of information, education for everyone, to fix everything. That's what global health education is. And if we talk about what the best practices are to do global health education well, it ties back into those learning objectives that I showed you earlier. So the elements of ethical global health partnership, and when you engage with your partners, are pretty simple, and it sounds no duh, but it's really complicated to do in practice. But we can really try to focus on our educational work, that we're doing no harm, that we recognize that solutions to problems aren't obvious, especially to a visitor. You do not have the answers, and you do not see the complexities that are behind the problems. You may have an opportunity to help if you can listen to and get kind of plugged in to have your partners share their agenda and their needs with you. And we have to practice patience, listening, and collaboration before anything else is done. In terms of equitable agenda setting for global health education activities, these are sort of the best practice lessons that I reviewed in the talk. We need to identify our partners' priorities, practice that equitable agenda setting, partner at all stages for everything that we do, set those clear expectations that I mentioned, and then create guidelines in a partnership. Don't create anything on your own. And last, I gave away my cute baby slide. It's the big finale. We need to identify barriers within educational collaborations, insist that all voices are at the table, and make that happen. And just to plug that even if you're just a student, quote unquote, you can be the person that suggests these things. If you're part of a team and the person who's leading the project on the US side wants to have a meeting with partners in Tanzania at 4 o'clock in the afternoon Chicago time, be like, hey, how about it's 8 a.m.? You can advocate for some of these things and really help address some of these problems. Also seek those opportunities to capacity build as you're going through your educational initiatives. There's the cute baby. So with that, I'll just say, again, I meant this to be sort of a menu of ways that global health education can occur. There's a lot of similarities no matter where the settings are. And I've done a lot of them. I'm happy to have anybody reach out afterwards to discuss more, and I think we have a little bit of time for questions, although I didn't see what time it was. Yeah. All right. So thank you. That's the talk. Let me know if you want to talk about anything. Yeah. Questions? You can just look at the baby. I think somebody had their hand.
Yeah, thanks so much for the presentation and for your work in global health and trying to address equity. Yeah, so I'm probably just curious, and considering that a lot of the work you're doing has to do with improving and strengthening systems in probably more of global South countries. So I was just wondering, in the course of teaching, what have you learned? What have you learned? And what can you say in terms of practice or way of doing things that you've learned personally that has improved your own practice, and possibly that you can bring back to the US?
Yeah, that's a great question. Like so much. I mean, that would be a talk on its own. There are so what people usually say, and what I always say, is that you're going to learn much more on all these experiences than you're going to ever teach or share information on. Personally, in all of the different settings where I worked in the various capacities, teaching learners, teaching health workers who maybe didn't know a lot about pediatrics, working higher up in organizations, directing policy, all of that. The biggest thing that I learned is that there really isn't any correct way to do healthcare, and things are going to change in every single context and every single setting. And if you come into any situation, whatever it is, visiting one place in the world from being from another, or going to another organization locally when you're working in a different one in the same location, you cannot have your own agendas. You cannot think that you have the right way to do things. So there's excellent ways of providing patient care. There's cultural differences in the way we provide patient care. There's different ways that we care for families and children in communities elsewhere that are very different than what we do here. And I would say the biggest part of what I learned in this work is just that fact that there is as much to learn elsewhere as you may want to bring, and that if you're going to engage in global health education, it's really going to be about that, showing your cards and figuring out how to exchange what you have and taking what the other person may have to share with you, and using all of that information or those networks or those projects to address those discrepancies in fair health. But it'd be hard to pick one thing. I would say that was my big overall lesson. Yeah.
Lisa, thank you so much. Wonderful talk. One of the things that you hit on that I think is really important and really a challenge for us is the listening part. That our inclination is so often to jump in and try to help and share our expertise, as opposed to first listening to both our partners and community members to gain their understanding about what is going on the ground and what the problems are. Historically, in other disciplines, this problem has been looked at and addressed and grappled with. Do you think in global health we're beginning to sort of incorporate some of the wisdom that has been developed in other realms as well to help address these kinds of problems?
Yeah, I hope so. I mean, I think we are. My impression from my time working in this field, which I think most of you know, it's now recognized as a new pediatric subspecialty. Did you all know this? It's an accredited pediatric subspecialty now, global. But anyway, in my time working in the field, and in the time that a lot of my colleagues who I work with who are in the back have worked in the field, there does seem to be, yes, more of an appreciation of that being the best practice, and also in the context of this whole decolonization of global health movement, it's there as well. So a lot of people, as they've come up through the global health specialty in the world and the practices, they've seen how not to do things, and they've been a part of partnerships that didn't feel right, or they saw practices that weren't good. And even if there were recommendations or guidelines in other fields or in other areas to address those, it wasn't always translating. The other thing about this sort of work is anytime you plunk or pick someone from their home country, culture, context, community, ivory tower, or whatever, and plunk them into another situation that's different, or the resource is different, or the power dynamics are different, nobody's on their best, day right then. It's uncomfortable. You're seeing things that you're not happy with, and so it's really, it's a type of healthcare provision and education and interaction that's just rife with problems, and can be because of the emotionality of it and the novelness of it and the culture shock and the power dynamics and all the things. So anyway, I'm babbling a little bit, but I think to answer your question, I think it now is becoming more systematic in how we're practicing global health education and designing initiatives, but it's by no means done. Yeah.
Mine kind of dovetails a little bit on his, but I was, reflecting on about a year ago at this time, we had Global Health Education Day, and we had a whole working brainstorming session with a lot of us that are involved in global health education to ask our colleagues from the upstream labs, what were we doing well? What could we do better?
Yeah.
And, I will say I feel very privileged to be working in a place where we're very, aware and intentional about how we send trainees into the field, and also the the opportunities that we have here at Northwestern for our partners, for sure. But I also feel frustrated that that's not universal. There's no real requirements. It's really just who's interested and who wants to do that. Yeah. And also there are still so many of these not-for-profits out there, similar to the one that you mentioned in Uganda, that are still there, that are still happening. Yeah. And so if you were, the ruler of the world, I guess, I'm wondering what.
Wait, I'm not.
I know in this, both in academia, but also just in this whole nonprofit world, right? What Judith Lasker wrote about how many years ago now? What kind of legal things could we put in place? What kind of regulatory things? What kind of accreditation things could we put in place to really move the needle on some of these things?
Yeah. Very good question, very complicated question. The things that are within our control, I think, are what's happening now in global health. So, initially, my colleagues and a lot of our colleagues from some of the big global health groups in the country, 15 years ago when they were starting this work, there was not much to guide anybody in terms of practices or requirements. And in the last 10, 15 years, there's all kinds of governance bodies that are putting out recommendations, like the American Board of Pediatrics has a program director's guide for global health programming. There's lots of recommendations about best practices for memorandums of understanding, contracts, all of that. And now, as global health is what it seems like now is things are a little bit more fixed for global health resident requirements and exchanges, and now the updates are sort of happening in the fellowship realm. So this accreditation for PEDS Global Health Fellowship is new, in 2023. This just started. So really having it be recognized as a subset of pediatric care that comes with different standards and requirements and rules, having those parameters in place is helpful. But then, because you're interacting with partners and communities and contexts where maybe you have no legal say or right or oversight, all you can do is just make things really strict for your own learners and your own faculty. And I've seen at a lot of institutions throughout the U.S., the restrictions and the rules that are put in place for residents are now starting to slowly expand out to also include faculty. Any faculty going abroad should also go through the same trainings for culture shock and preparation, and just making some pretty blanket recommendations, if not rules. I don't think they can be rules. They could get quite restrictive. But recommendations for how people prepare, engage, and just learn how not to be a jerk when you're going abroad, and how you don't trash relationships and make everybody hate you.
Statement.
Yeah.
No pressure,
Yeah.
do no harm.
Yeah. this is often what I tell people the classes I teach are on. I'm like, this is going to be the how not to be a jerk in global health course. And it's true. I mean, it's just all the things that you need to know. So I think that's all we can do. I mean, you can advocate as you're engaging with partnerships, and you see gaps that are leaving people vulnerable, you can advocate. But really, I think at this phase and where we are for global health, it's just tightening up our own ship and making sure we all have rules that we're abiding to so that we aren't being a jerk and causing more harm unintentionally.
We have time for one last question. Oh, 2 more questions. I think that'll be.
Thank you so much, Elisa. I'm Juliet Kabirigi, a pediatric cardiologist from Mwanza, Tanzania. I'm so happy to have this opportunity, and I'm grateful to Global Health via Christine, Elizabeth, Colin, for the opportunity which helped us to be here. And I think it's the best timing. Thank you very much, Lisa. And you have been inspiration, especially to serve vulnerable population, because with this presentation and the work you are doing, it seems every life matters, and that is very good thing. And for me, I have just a small request, because you have this experience of doing work to this kind of environment. For instance, for me, personally, I'm a pediatric cardiologist who's serving about 6 regions in Tanzania and the Lake Zone, and it's very hectic to serve all these children. And our challenges. Health insurance is an issue. We have this monster disease like rheumatic disease. And most of the time, the children are presenting already with heart failure, with all those pulmonary hypertension, all those kind of complications, So this was touching me because children are not going to school. Families have been a lot of issues in order to summarize. So I wish, because my area of interest is to do preventive pediatric cardiology, because I need to put a lot of energy on that. So may you please help me to mentor me, especially on research point of view, at least to guide me how to go about. Maybe I can do some of consultation, because I really wish to help these kind of populations. There's a lot of issues, but I want at least to be specific on this kind of problem. Thank you so much for your nice presentation.
Oh, thank you for those. Let's learn from each other later. Oh, yeah, we should talk. How many cardiologists are there in Tanzania total? Do you know? Yeah. So most of the patients, they fail to reach there. Yeah. So what we need to use the low-hanging fruits to save at least some kind of thing we can do. Yeah. For instance, we have started, because we have graduated, I and one of the cardiothoracic surgeons. So we say at least let's start with doing PDA closure. Because at least those are the people who have large PDAs and they can't reach it to Dar es Salaam, where there's cardiac institute, where they can be, where they can do devices and other things. So at least we say, let's start with this one where we are preparing the environment for larger things to do. Yeah, how global health embeds in the pediatric subspecialties is kind of a whole other thing that's going to be evolving over the next 10 years. Locally, too. I mean, the local outreaches like that are a key example. Do we have time for one more?
Yeah, last question.
Hi, thank you so much. That was a great talk. So for a little bit of background, I'm pediatric rehab, and I'm at the beginnings of building a collaboration with a partner. And I was curious, from your perspective and your experience, do you have like a more successful way of eliciting a needs response and doing that study within a community? Because right now my answer is anything you got, we need it all.
Yeah.
And I'm like, okay.
Yeah. So, I mean, in my experience, there's such a power dynamic when two like potential global health partners come together that there's a potential to do a lot of work and a lot of collaboration, but nobody wants to scare the other person off, right? So the people who are from the lower resourced partner side, whether that's locally and someone outside of our ivory tower in academia, or whether it's an international partnership or domestic, whatever it is, the person who might want some input from a bigger partner with more resources isn't going to want to scare you off, isn't going to want to actually say anything, and then vice versa. You know, you have your own things that are maybe blocking you from having like a real honest discussion. I mean, in my experience, it's just time, and it's about getting that social capital and that time to prove to each other that you really both like kind of want to work on the same thing, which is address something that's important to them, but it's not going to come out right away. So it's usually just time. It's making sure that you have enough like Zoom meetings ahead of time to get to know your partner, spending time on ground with them, being quiet and just watching and just seeing and talking to people and doing needs assessment. And it's slow. Like I just had a PMNR resident come and talk to me because she wants to create a curriculum for partners in Tanzania at a site where she never worked. And I was like, how about for your first trip, you just go, get to know people, and like plan your needs assessment and see if you can work with a few people there to design something that might get the information in a good way. It's usually just slowing down the brakes or pumping the brakes and slowing down and going back and trying to give time for that like trust and that ability to be really transparent to come out, because it usually won't be there right away. Yeah. Okay, thanks everybody.
Thank you so much, Lisa. We often really, sort of give our learners the advice of the things like not to do and how not to cause harm and what we've learned over the years. But I love that you have some answers of things that can go right. And just this even question from Elizabeth, like this idea of just time, just like years, just showing up over and over. Like it requires a lot of patience that we don't really have as academics or in our institutions. But thank you so much for sharing. I think we have a lot of other questions for you that we'll ask you later. But now we will turn it over to Dr. Carlos Faerron Guzman, who will be introducing himself and his talk, so making this easy for me. Thank you so much for coming. We're really looking forward to this.
Thanks, Ash. I'm going to use this.
We're just going to take two quick seconds for a quick technical break.
Technical, I don't want them to do it fast enough.
This can go in your belt or a pocket, and this one button on turns it on. Okay, and this right here, Dr. Guzman, it'll go right here. Take us for. Let's get you set up with your laptop. And you want to make sure that your computer is back.
There you go. Sorry. Can you hear me all right? Wait, am I on? Am I on? On? Yes. All right. Is that volume all right? Yes. All right, thanks. All right, great. All right, thanks, everyone. Thank you for the invitation. I really appreciate being here in person. I actually teach a course at Northwestern, so it's actually my first time in Northwestern. So it's kind of odd in this virtual life that I teach in an institution that I had never stepped foot on, such as the virtual world today. Again, pleasure to be here. My name is Carlos Alberto Faerron Guzman. You can tell by my long name that I come out of a Latin American telenovela. That's the first time I tell that joke. Anyway, I am a Costa Rican. I'm born and raised in Costa Rica. And I live in Costa Rica for most of the year. When, if not, I'm traveling for one of my work appointments, like this engagement here today. I chose this because I want to walk around to keep you awake. So I'll be pointing at you just in case. Don't feel threatened. It's just me trying to keep you engaged. And I know it's a hard time of the day. What else should I say here? I want to say hello to my peer, global health educator, because that's how I identify myself as well. I come more from the planetary health realm. I've been engaged as a planetary health, a global health practitioner. I first was what I called a public health practitioner. I'm a clinician by a background, physician. I started my career in 2010, working in a rural community, indigenous rural community of southern Costa Rica, where I worked for 2-3 years. And because of the relationships and what I learned from the communities, I started intersecting the worlds of environmental health and global health, eventually what became this term, planetary health, that I'll be speaking about today. So I spent some of my time in global health education. That's my appointment at the University of Maryland, Baltimore. I direct the Master's in Global Health there. And I teach at the University of Maryland. That's my main appointment. And as well, I work with at Johns Hopkins University in the Planetary Health Alliance, which I'll speak to a little bit later. Just in case, I want to know, I gave a virtual lecture similar to this one maybe 3-4 weeks ago. Were any of you part of that? Okay. Some of the jokes might be the same, but I'll try to give them a little curveball. That's good, because so you're hearing this for the first time. It is kind of the first 30 minutes, 25 minutes might be the same, and then I veer more to the education component in the last, let's say, quarter of the presentation. Show of hands. I know that a lot of you are clinicians, but show of hands if you are aware of the term planetary health. Has any of you taken my course? No. Okay, good. Okay. So a lot of you are, and this is really good. This is very relevant to clinicians, and I'll try to tell you a little bit about that. So I'll just skip through my next slide. I'm going to try to use this. I notice that I use this a lot in my virtual talks, but when I'm pointing here, where did it go? You see? This is what happens. I don't know what happened. You see? Now I ruined it all. Something's happened here. All right, so let's just start here. So I'm going to try to use this. But I use it online, which is easier because I can see where it is. I can't see where it is. There you go. You see, this is not easy because I don't know where the pointer is. It's just appearing. So maybe I won't use it, and that's just easier. Is this a pointer? This thing's vibrates. I don't know if it's a pointer. Nope. Can you see anything? Or is it just me? Anyway. All right. It's all right. I'll try my best here. As I was saying, where was I? This is where I want to start, because a lot of times when we kind of look around us and what's going on around our current state of affairs, we get the feeling that things are actually worse than ever before. Who's gotten that feeling before? Raise of hands. Lately, you open up your Twitter account, you turn on Fox News if you have Fox News or CNN or Telemundo, and things seem like it's worse than ever before. But it is a lot of noise out there that makes us think like that, and we have to really take a step back to really showcase that as a global society, we've actually made a significant amount of progress, right? And those are the numbers that don't let me die. The timeline there, if you can't see it, that's 200 years in the past. In the last 200 years, we've moved from most of the people in the world living in extreme poverty to today, only 9 out of 100 people live in extreme poverty. That's still a lot of people, but that is a significant amount of progress. People are accessing education like never before on all social strata. There's still a great amount of people that don't receive it, but you can see there's progress. Our economies has grown significantly, going from, let's say, zero, where maybe a couple of $1 million a year, to $120 trillion last year in 2023, which is a huge amount of growth. More people today are living in a democratic country. That is, they have a political voice than ever before in history, although in some countries in the world, yes, democracy is backsliding. So countries like this one, I think, is a place where democracy is backsliding, but it's not the only one. Russia, Turkey, Philippines, El Salvador, these are countries that are having issues with their democratic principles, but still, never before, have more people gained access to a democratic way of living. And then when we look at health, which is a little bit what we're going to talk about today, we see that health actually today, access to health systems, health technology, preventable access to life-saving medication from preventable deaths or easily preventable deaths, have made significant progress. A lot of that is because of the work you're doing. A lot of it is because boring things like health system strengthening, which I was going to tell a joke, but I'm not going to tell it. I am going to tell it. Paul Farmer, rest in peace, he used to say that health system strengthening was the most important thing we could do in global health, but it didn't have a sexy enough name. So he said, let's just call it Beyonce or something like that. That's what he used to say. Anyway, so just taking a step back, we see that things are actually improving. So if it was to summarize this slide in just one slide, one name, I would say progress. Right? Progress is a good way to point out where we are in all the things that humanity has said are important, be it housing, be it gender parity, be it access to a political voice, access to water, all those things that we have deemed important, we have managed to improve over the last 200 years. So don't say that things are worse than ever, although they seem like. There's a controversial author that writes a lot about this. Some of you might have read his books, Steven Pinker, Better Angels of Our Nature, Enlightened Now. Those books touch around these things, and I think it's important to get that grasp of things. And all those things have been happening in this context of, is it picking up twice? In a context of rapid population growth, as you can see from this slide over here. And the timeline here again, the last 200 years, you can see that our population has also grown quite rapidly, just like the other things we were seeing. Improving population growth has followed as well. And we might say that another thing that has been increasing is life expectancy, as you can see there, which is what I say, it's a proxy of better health, I would say. More people are living longer lives, probably healthier lives as well. They're not dying of easily preventable deaths. So if we were to combine these things like poverty decline and life expectancy increase, and we were to put it together in, let's say, a composite index, we might say this would be part of what we would call a well-being index. And that well-being increase is happening in a moment in time where we're seeing rapid population growth. And this seems paradoxical because many people, I'm going to use the whiteboard here, many people thought that, old school, yes, actual whiteboard. I need a chalkboard, though, to be real old school. Many people thought that, that this is time, and this is population, right? And I'm going to draw another graph here, and this is time, and this is vital resources, let's call them, right? Many people thought that if population was growing this way, exponentially, like we see in the graph, resource was only going to grow this way. And then when you put these together, there was going to be a mismatch between resources and population. Vital resources like water, like land, like food, like those things that actually keep us alive. And because of this mismatch, then people thought that what would happen to population, right, in this mismatch where there wouldn't be enough food, water, shelter to go around, then population would eventually decline and probably stabilize in a period where there was enough resources to go around. What scientists back in the 18th and 19th centuries and even into the 20th centuries, another book that I think anyone should read is Population Bomb by Paul Ehrlich. It's a book that we have to learn about not how to do things or how to think about things, is that actually resource use, right, actually also grew, or resource capacity, our capacity to extract resources, also grew exponentially. You know, the more coal we had, the more capacity we had to extract coal. the more energy we are able to extract from under the ground, the more energy we're able to produce, right? And so on and so on, right? It's a virtuous cycle of production and resource extraction. And so this never happened. And this is why we continue to grow as a population, because we have access to very, very rich amount of resources. I'm going to skip through these slides because of time, just so I can get to the last slides, which I think are the most important. So this is now, I want you to imagine, because you're mostly clinicians, that in the waiting room, right, of your clinic, there's a set of planets there. And these planets come to consult with you, and they're like, hey, you want to take my vitals? That's the most important thing that you're going to do first, take your vitals. So what if I was to ask you, and we were to take Earth's vitals, planet Earth vitals, what would those be? Temperature? Definitely, okay, we would see. Okay, that's a good one, yeah. Temperature, anyone else? Probably, yeah. We want to check for dehydration. Blood pressure. We would look at the atmosphere, right? We would look at the things that are living on Earth, just like we check for bacteria and stuff like that. They would probably check on, let's look at what's living on Earth. What else? The oceans, right? Let's say our blood circulation of Earth, the rivers, the water, the oceans, we would look at those, right? I'm sorry? What's habitable? Yeah, exactly. We start looking at different parts and organs, the different ecosystems around the world. How are the forests? Yeah, we would look at things like pH, the carbon, the oxygen, right? We would look at all those things, so we can do that, right? So let's say Earth comes into our consult, and we're like, what are we doing here? What are we looking at here? Okay, here's how the vitals are doing. And so obviously, we're not doing that great, despite the fact that I just said we're doing better than ever. I then consider the environmental conditions that were around us. So this is what a little bit about planetary health is about. So when we look at things that we need to keep ourselves well, right? Things like energy. Energy is kind of this primary input that goes into everything. It goes into our food. It goes into our clothing. It goes into our health system. It goes into our industrial system that keeps the economy growing. It goes into the transport systems that put us A to B and transports all the goods that we need. It keeps the lights on. It keeps the AC on. It keeps the heater on. Energy is this primary resource that we need for absolutely everything we do in our modern life. And where is that? Most of that energy is coming from where? Obviously, fossil fuels. Yes, there's an increase of renewables. It's still not enough. It's still mostly fossil fuels. So you can see that as well. The timeline there is also 200 years. Energy use has increased. But so has other vital resources that are no longer renewable. Who learned in school that water was a renewable resource? I think I did, actually. Yeah. That's like in my textbook in science, it says, water is a renewable resource. Like 10 years later, it's like, no, it's not. It's non-renewable. It can actually go away. And that's what we're seeing as well. Other things that keep us well, like primary materials, like what comes from the forest, timber and such, that gives us shelter and gives us energy. Biodiversity in the form of food, we're also increasing the amount that we're capturing. And then we're increasing as well the use of these other things like fertilizers that actually exponentiate other resources like land and food. So we are using a lot of resources from Earth, a lot. And these are just examples of them. And of course, these amounts of resources, as you're already suspecting, has consequences over Earth's natural systems, right? The more water we extract, the more water shortages we see around the world, right? The more energy we burn in the form of fossil fuels, the more greenhouse gas emissions we see, things like methane and CO2, right? The more we change and use up biodiversity in the form of food and cut down our forests and domesticate land, the more things like biodiversity loss we see. So the consequences of our over-extraction are quite clear now. And we need to remember that our well-being depends on these very things. So I spoke about the fact that our well-being was increasing. And that's true. That's the first how I started. Well-being is increasing around the world. And that well-being is sustained by Earth's natural resources. But today, we have over-extracted so many of those Earth's natural resources, we have altered those ecosystems that keep us well to a point that now we are endangering that gain of well-being for some, and some are already seeing the consequences of those Earth's natural systems being severely altered. And that's what kind of those initial graphs are telling you about. Now, I just spent, 10 minutes, 15 minutes talking about the last 200 years. I'm going to go back now 4.5 billion years. And I'm sorry I'm doing this. But it's important to understand where we are on Earth. So prepare yourself. This is a timeline on Earth. Now, is anyone a geologist here? Does anyone love geology? There you go. One person loves geology. Geologists, what they do, they literally dig holes into the ground, look at the layers, and try to study, based on what is on the rock, what happened millions or billions of years ago. This is what they do every day, right? They look at the little layers of the rocks and say, what kind of animals lived during this layer? What happened? What was the atmosphere like? What was the temperature like? They could even look like what was the CO2 concentrations like if they're looking at ice. What was the type of biodiversity that lived in this space? So we have to go back 4.5 billion years, that's 4,500 million years ago, to start seeing the formation of Earth, right? And after that come these things called eons, right? The Hadean, the Archean, the Proterozoic, the Phanerozoic. They have very, very weird names, but eons are divided into eras, eras into periods, periods into epochs. As you can see, the timeline is kind of zoomed in as we're coming into today. So the Phanerozoic divides into these eras. Within the Phanerozoic, we're in this era of the Cenozoic. Within the Cenozoic, we're in this period of the Quaternary. And within the Quaternary, we're supposedly in this thing called the Holocene. Holocene describes this era of stability in Earth's climatic systems that allowed humans to thrive. Now, when you think about this resource that I haven't mentioned, stability, it becomes really important to note that stability of the climatic systems is what allowed humans to develop. For many hundreds of thousands of years, there were hominids roaming the earth, right? That is human-like species roaming the earth. And then Homo sapiens came along around 250,000 years ago. Now, Homo sapiens adapted well to the environment, but really didn't grow. It just kind of stabilized throughout around 230,000 years. It didn't do much. It just kind of, roamed around the earth. But after the last ice age, we entered this Holocene, and suddenly there was stability of Earth's climatic systems, where every year we could actually predict exactly what would happen next year, and then exactly what would happen next year, and then exactly what would happen next year. And that knowledge started accumulating generations after generations, and then the people that were living in during those times went through what we call the agricultural revolution, which was a period of time of 6,000 years, 7,000 years, more or less 9,000 years before current era to 3,000 years current era, in which we developed things like cities and complex language and literature and agriculture and division of labor and caloric surplus, etc., etc. And that put us on a track to where we are today. So that stability that we hardly regard as important is what allowed humans to thrive to where we are today. And that's what the Holocene is, that period of the last 12,000 years. And I was saying, I was talking about the geologists. These are literally like those fragments of Earth that geologists look at. So as you can see, the deeper we go underground, like the deeper we go on the layer, the further back in time we go, and the more recent times are the ones that are more on the top layer. Now, I want you to imagine we travel in time in the future, not in the past, but we travel in the future, and now we're looking 1 million years. We're 1 million years in the future, and we're looking back at today, right? And there's a geologist in the future, very brainy person, geologist of the future, looking back on today. They're studying the rock layer of today. And they're saying, these humans from the year 2024 really had a particular way of living. What is it that they're finding in that layer of Earth that is allowing them to say, hey, this Holocene really is an odd time in the geological period? What are the things? What do you think they're finding that they're saying? I can really tell how humans were living in this moment of time was very different to the rest of time before us. Any ideas? More carbon dioxide. They could measure the amount of carbon dioxide on that, and they would say, wow, they really were going through a really high a level of CO2. Might not be clear to them in the future why that was. We know why it is right now, right? Because we're burning fossil fuels. But in the future, they might not have that all that clear. Maybe the technology will allow them to say that. Okay, higher CO2. What else? Plastics. Plastics are from fossil fuels. They'll probably find some traces of microplastics. A million years from now, that might be a little harder, but some traces might remain. Right, and they'll say, what's this plastic thing? Plastics have only been around for the last 100 years or so, and they became prevalent in the last 70 years. That's how new plastic are. And I don't know if you know, but plastic is everywhere now. It's in our food, it's in our system, it's in the bottom of the earth, it's floating in the clouds, it's absolutely everywhere. What else are they finding? Forever chemicals, like which ones? Yeah, there's a lot of forever chemicals that we've created, like these compounds that we've created artificially that can sustain through time. And not just chemicals, but things like metals, metal alloys that we've created to create our batteries, to create our cars, to create infrastructure like these. Those metals will live on through time. Before our time, there was no metal in the natural record, and now we have them. They'll be seeing a lot of that activity. Things like cement, asphalt, all those things they'll be able to see there in the fossil record. What else? What will they stop finding? Before our time, they'll see the fossil record and they say, there was so much biodiversity before humans. After humans, they'll say, wow, what happened here? They'll also find a lot of chicken bones. I'll tell you what, that's 70 billion chickens we kill each year. Billion, 70 billion. A lot of chicken, hopefully chickens will become our overlords. It's fair time telling that joke as well. All right. Anyway, so that's what they're going to be seeing. And this is why geologists today are starting to question, wait, have we moved through a new geological epoch? Have we moved from this era of stability to this new era where humans are now the driving force of this new of geological time? And so they've proposed this epoch of the Anthropocene, which literally means the era of humans or the epoch of humans, Anthropocene, right? So this term is still contested, even if you were reading the news lately. This was contested recently by an international society that decides when the Earth moves through a new geological epoch. But it doesn't mean to say that just because they're saying, no, we haven't moved there yet, it doesn't mean that we humans are not having an important impact over Earth's natural systems. So what do we do in planetary health? And why am I telling you this story that went back 4 billion years ago? Planetary health basically tries to understand what is health in the Anthropocene, right? How is health affected in the Anthropocene? And this very complex schematic illustration tries to explain that. So what I'll do, I'll try to spend 5 minutes explaining this, and then we'll move on a little bit of why you should be learning about this. So here we go. They're going to use my high-tech PowerPoint skills to try to show this. Okay, so what we're going to do, instead of reading it from left to right, we're going to go in that order, 1, 2, 3, 4, 5, and then we won't get to 5, but if you want to take a mental picture of 5, we can have questions around 5, which are the underlying drivers, which I think there's a lot of conversation to have around 5. So here we go, okay? Mental picture, start now, high-tech PowerPoint. Here we go. First thing you need to understand in planetary health is that there are these ecological drivers of change that we call anthropogenic changes to Earth's natural systems. Anthropogenic because they're human-caused changes to Earth's natural systems. So things like pollution, pollution of our airs, pollution of our waters, pollution of our soils, pollutions with non-organic compounds, organic compounds, heavy metals, forever materials. All those things are now seeped in every ecosystem in the world, whether we notice it or not. They are not just local, they're now happening at a global level, right? We can find microplastics in absolutely the most remote parts of the earth. We can find traces of heavy metals in absolutely almost every fish species on the earth, et cetera, et cetera. So that's happening at a global scale. We're also seeing a very rapid decline in our biodiversity, not just those humongous, pretty orangutans or apes, the rhinos. We're also seeing loss of biodiversity of species that we will never even know existed, amphibians, protozoas, bacteria, that are disappearing from this earth, that played a role in the web of life, but we don't even know about them because we didn't even get to discover them. There's only a fraction of biodiversity that has been discovered, but we know that this is being declining quite quickly. We're also seeing alteration in the biogeochemical cycles. Now, as you know, the Earth cycles several types of biogeochemical materials. Things like carbon cycles through the Earth in the form of life forms, in the form of soil. It can even go into the air, it can go into the water, and it cycles through, similarly to oxygen, similarly to CO2. There's some of these cycling elements that are now being in excess, that we have put there in excess thanks to our capacity to create things like fertilizers. So things like phosphorus are now in an overload in our biological system. That means that there's an excess of phosphorus in different ecosystems like the water. And when there's an excess of phosphorus in the water and nitrogen in the water, we have consequences like eutrophication. Have you heard of eutrophication before? And so eutrophication is a phenomenon where, due to this runoff of nitrogen and phosphorus specifically into the waterways due to agriculture, it creates these gigantic dead zones of algae blooms, right, in which the algae and the bacteria that are next to this algae consume the oxygen and doesn't allow any other living form to be there. Now, I don't know if you know this as well, but let's say the Mississippi River obviously has a gigantic dead zone in the Gulf of Mexico, and part of that fertilizer runoff comes from the Midwest, right? The Midwest is a gigantic, what do you call it? Is it breadbasket? No. What do you call it? Yeah, something, I don't know. But the soy, the corn, all that uses massive amount of fertilizers. Fertilizers are mostly nitrogen, phosphorus, and potassium. There's a lot of runoff that goes into the rivers, the smaller rivers, and the tributaries, and then the Mississippi, and eventually down to the Gulf of Mexico, and creates these gigantic dead zones. These are spread throughout the world. Obviously, the Gulf of Mexico is just one example. There's changes in land use, so cutting down forests, but also using natural grasslands for agricultural activities, the expansion of cities, all those counts for land use change. There's scarcity of resource. I mentioned the scarcity of water. There's changes to our oceans. Oceans are becoming more full of pollution. They're more acidic. They're more warm, thanks to CO2 accumulation as well. And then there's climate change, which I leave last because it gets a lot of attention. And then we look at this figure and we say, okay, that webby thing, just trying to illustrate the fact that all of these are interconnected amongst each other, right? So let's say you can have land use change, which is where you take land and then you use it for agriculture, and then you use a lot of fertilizers, and then you have nitrogen runoff, and that could alter biogeochemical cycles. At the same time, that could alter biodiversity loss. At the same time, that could alter global pollution. And at the same time, right, all those things can be in a bilateral way and interconnected to other things like biophysical ocean changes, which at the same time can be connected to climate change. And then climate change can lead to other forms of land use change like forest fires. More forest fires can also lead to more climate change, and so on and so on. So some of these can get stuck in what we call positive feedback loops, in which things are getting exponentially worse very quickly, reaching what we call tipping points, in which there is the rate at which these change are happening very rapidly and in unexpected ways. This is what we call tipping points in ecosystem science. So that is happening, right? All these are happening simultaneously, feeding off each other. And then, as you're already kind of starting to notice, these things affect people's health, right? And we're seeing changing patterns of not just emerging infectious diseases like more dengue, more malaria, more chikungunya, more Zika, which are vector-borne diseases that we know are secondary to things like climate change and loss of biodiversity and loss of land use change, right? Those are a good example of how these are all interconnected, leading to things like more emerging infectious diseases that are vector-borne, but also changes in non-communicable diseases, changing in nutritional diseases, changes in mental health-related diseases, changes in sexual and reproductive and health. So it's changing basically the makeup of our burden of disease throughout the world, usually for the worst, So in planetary health, we try to study the connections between these two. And then we use these frameworks, right? Frameworks that you're already quite aware of, which are the determinants of health frameworks, in order to connect how these things are connected, or how our anthropogenic changes to Earth's natural systems related to changes in the burden of disease. So whether it's the quality of the air, whether it's exposure to harmful substances, whether it's a different process in food production and food systems, whether it's through migration and displacement, whether it's through infectious disease exposures, et cetera, then we understand that all these kind of direct exposures are funneled, so to speak, or seeped through the different determinants of health. It's not the same to be a woman than a man, and the exposure of these can be changed. It's not the same to have high socioeconomic status to low socioeconomic status. It's not the same to be in a place where there's a strong, resilient health system, where in a place where health systems might be very weak. It's not the same to be in a place where there's high reliability, high responsiveness of that health system versus a place where there's no high responsiveness. It's not the same to be in a place where there's policies in place, where there's no policies in place. It's not the same to have genetic predisposition to some of these things versus there isn't. So we look at the different determinants of health, like I said, in order to understand how these anthropogenic changes of Earth's natural systems are impacting differently different populations around the world. And you can start already thinking, oh yeah, I understand this quite well, and I'm seeing this right here in Chicago, how things like climate change, water insecurity, food insecurity is impacting differently different people around the world. So the degree of change is different, of course. So because you are experts in this, I won't overview the determinants of health, of course. I won't give you my intro to the determinants of health. I will say that when we understand the determinants of health, and this is a conversation that we rarely have, we need to understand that, and this is the interpretation of determinants of health is here from a complexity lens, means that health, we need to start understanding health as a product of this eco-social system. So health can be understood as the interplay or the resulting product, the resulting dynamic product of the interplay of all determinants of health. But what determines the determinants of health, or what I call the mother of determinants of health, is values. And we rarely talk about values when we talk about policy, because if we really want to see change in the world that we live in, both from the global health side, from the planetary health side, we need to talk about values. Values is the structural things that everything else is built upon. This is why I call it the mother of determinants of health. And we can talk about values in a second. So in summary, what do we do in planetary health? We try to take these this is obviously artificial intelligence here image. I don't know if someone recognizes how artificial intelligence create images, but this is more or less what they look like. You can see the faces are all wrong, but anyway. We take these very complex, this is number one, 3 things we do. We take very complex, very puzzling, very daunting phenomena, and we try to put that in language and in frameworks that then are digestible and are usable and then be contextualized to the lives of different peoples, different sectors around the world. We try to provide a message of hope, which I haven't done just yet, but I will eventually provide a message of hope that we are still in time. There's urgency, but there's still time to fix some of these things. And then we create common platforms in order for people to collaborate. People like clinicians, people like policymakers, people like business, people all around the different sectors on how to collaborate. These are the kind of the 3 principles of planetary health and the 3 key areas in which we work with. I want to spend some time talking about these three lenses by which we can look at planetary health, which is the lens of power, the lens of equity, and the lens of complexity. These are not the only lenses that we use when we talk about planetary health, but they're useful for us in this lecture. So let's look at things like equity and power together, because we know, right, that obviously because of how economic systems are set up, because of just the very nature of weather and the very nature of climatic systems, the very nature of our ecosystems, but also the very nature of how nations are built, there are different degrees of vulnerability around the world to things like climate change. As you can see there, countries in what we would call, quote unquote, the global south tend to be more vulnerable to a climate change and other changes in our natural systems. And as you can see, countries in what we call the global north are less vulnerable. So here, vulnerability is a mix. It's a composite index that takes into account many, many variables, such as infrastructure, such as socioeconomic status, such as GDP, many other things. All right, so this is important to note, because when we look at vulnerability, right, we're talking about basically the mixing of concepts like risk, adaptation, or adaptive capacity. We're mixing those concepts together. So what does this look like in real life? Let's take this example in these two photos. So one photo is taken in a high-income country, the Netherlands. The other country is taken in a lower middle-income country, which is Bangladesh. So to the left, you have an example of how the Netherlands is weathering sea level rise. These are literally floating houses. They're building houses on the shore, and they know sea level rise will come because they have the financial means, the technological means, the knowledge means, the social means, the policy means. They have all the resources there in place. They can create these floating homes. Basically, sea level rise, no problem. The house rises with the sea. To the right, we have Bangladesh, a country that struggles economically, politically, with infrastructure, developing as a lower middle income country, obviously has its challenges. And the capacity to adapt obviously will be less. This is our extreme examples. And in between, we have everything from where you all are living in, how it's happening here in communities in Chicago, access to things like air conditioning, access to or being exposed to things like food deserts. All those things are happening and are related to these issues. So we can take this as an example or an extreme example of two variables. There are other ways that these changes will affect us that are becoming, let's say, more understandable as we advance with our science. This is part of planetary health science and food system science in this example. So I was reading just before I came here that the fact that with a warmer weather in the Midwest, actually the productivity of corn will increase because there will be longer periods of time in which corn can grow. Warmer weather, less freeze, more CO2 even, which is CO2 is greening the plants, right, means that there will be more corn. And people say that's relatively good. More corn, more soy, more productivity, more money, better livelihoods for everyone. But when we look at kind of what the data and the science are telling us, it's something different. In a higher CO2 exposure, there might be more productivity, that is more per hectare, more crops per hectare, more yield, right, is the technical term. But when we look at the microscope and we look at what that yield is actually yielding, we see a drop in micronutrients. Higher CO2 environments means that micronutrients actually drop. Things like zinc, protein, iron. And when you have a population that might be tinkering right there on the border of malnutrition or undernutrition or anemia, and you expose them to lower levels of these staple foods that might be even the most important in their diet, you're risking the health of that population, right? So greening CO2 is actually having consequences over malnutrition and diet. And the risks is that around 200 million people around the world will be expected to be pushed under zinc deficiency, under protein deficiency, and anemia. These are 200 million extra people that will now be with a new burden of disease that they didn't have in this new CO2-rich environment that we're aiming if we don't do anything. And who's to blame? Who bears the responsibility? Well, when we look at these data, right, and we talked about vulnerability and who bears the brunt of vulnerability, we need to also ask the question, who is causing more damage to the environment? Who has the highest ecological footprint? Who bears the responsibility of CO2 emissions around the world? This graph shows that the richest 5% of the world, right, is responsible, as you can see there, more or less for 35% of the growth of CO2 emissions. That reaches 10%, around half of the growth of CO2 emissions is the responsibility of this few 10%. Whereas you can see the poorest, economically speaking, only represent the 6%. So in Spanish we have a saying, which is, who speaks Spanish here? We say, well, I mean in Costa Rica at least we have a saying that says, usted se come la piña y a mí me duele la panza, which means you eat the pineapple, but it is my tummy that hurts, right? So this is similar to what's happening. So when we talk about equity, this is important to talk about who bears the responsibility as well as who bears the brunt of the impacts that this is happening. This is a very starking image as well. This is called the cartogram, in which we can see at the top, the wider the country, the bigger the emissions, right? In this case, you see the industrialized, quote-unquote, world, like the United States, Western Europe, Central Europe, Australia, Japan, China, had the highest emitters, and below are the mortality that are related to climate change. So as you can see, countries in what we call the global south, or less industrialized or lower middle income economies, are the ones that bear the impact of climate mortality. And this is the same if we look at climate morbidity. So why should you care? So why should clinicians here care? And of course, I think you've probably seen these graphs more times than I. These are just put there before I got here. I was researching a little bit about how the Midwest will be impacted. Obviously, in the Midwest, we're already seeing higher average temperatures. You're already seeing less freeze days. You're seeing more days over 100 degrees. You're already being exposed to that today. That will only keep getting worse. And that relates to many things, not just, well, it's hot, well, I just have to turn on the AC more. Obviously, it has consequences. Everything from crime is related to hotter days, right? Homicide is related to hotter days. That's just one example. But there is aspects to food security, stress, heat-related pathology, destabilization of things like diabetic patients, hypertensive patients tend to behave or tend to deregulate their pathology more when there's hotter days. And some people are saying, yes, but less people will die of cold. Less people will die on the street. That is true as well. But the consequences of that will be multiplied many more times when we look at the full picture of consequences like this. Like crop yields as well, water access, pollution, emerging diseases, all these things will happen in a context if we continue to. So why should we care? Because it's happening in your backyard, right? This is one of the reasons why you should care. But also you should care because if you care about justice, and I think if you are involved in global health, if you care about justice, you have to care about planetary health. There is no separating those two things. This is a status quo scenario diagram in which in the y-axis we're seeing relative health gains or relative loss gains, and in the x-axis we're seeing the degree of environmental change. And here what we're doing is we're graphing two populations. The top population that you're seeing graph is what we're calling the populations with more power, and in the bottom is the populations with less power. Now, what do I mean by power here? Usually when we talk about power in the global health literature is involving one of these variables. These are the variables that we see in the global health literature that are taking account when we talk about power. Things like age, the unborn, the elder, etc. Or sometimes we're talking about income, low income, high income, living in poverty, not living in poverty. Sometimes we're talking about status of development, developing, developed, industrialized, industrializing. We talk about high development, low development. Sometimes we talk about power in this unidimensional concept of participation and representation, like people that are marginalized, people that are included. Other times it's geographical or historical variables, like the global north or the global south, like the West, the rest, the first world, the third world. Obviously, some of these are not used anymore. Sometimes it's a matter of race, ethnicity, gender, sexuality, religion, like minorities, people of color, heteronormative, etc. These are the ways we speak about power when we talk about global health. But we need to talk about power, of course, in a multidimensional way, which is considering all of these. Right? So it's hard to put a number on these. It's easy to put a number on age. It's easy to put a number in socioeconomic status. It's hard to put a number of power in multidimensional way. But obviously, we need to consider all of those. So this is just to say, when I'm talking about power in this graph, I'm saying all those things. It's not just the rich. It's also the people that have more political voice. It's the people that are taking part of the majority. It's the people that have the access to the policy power, the political power, the soft power, the hard power. All those things. And those exist not just in the global north, they exist all around the world. In Costa Rica, we have extremely wealthy people. In Uganda, you have extremely wealthy people. In Tanzania, you have extremely wealthy people. It's not just a global north, global south thing. This is a differentiation that we need to make, that this is not just happening in the global north, right? This is happening everywhere, this differentiation. And it's getting worse even in countries like mine, in Costa Rica, where inequities are actually the highest in Latin America, which is not something you expect to hear about a country like Costa Rica. So people with more power, paradoxically, as you can see the top graph there, are actually gaining health. Despite global environmental change, as you can see there's a little thing that says today, despite global environmental change happening right now, people of higher power status are actually gaining health. And this is one of the reasons that they're not acting, because they're like, everything's fine. The room is burning, but everything's fine because my health is gaining, my children's health is actually getting better. My peers are getting better. So I delay action because I think and I fear that if I change things, my gains will be lost. This is part of the problem that we have. This paradox, it's called the ecological paradox. But the ecological paradox is obviously only true for the people that have more power. When you start seeing health gains or health losses with the people with less power, the less people that have less political voice, less socioeconomic status, less access to education, less access to economic means, you see that their health has already been impacted. So the ecological paradox that is described in the literature is not true. It's not true because the majority of the world is already suffering the consequences. And that is not just increasing the health inequities, but it's also making the power inequities worse in kind of this negative feedback loop. But, of course, there's no escaping environmental change. And in the future, if we keep this status quo scenario, everyone will suffer the consequences. Once we reach tipping points, once food systems collapse, once biodiversity, food webs collapse, once we see climate change reach a degree to a point where we can't actually continue a society, all people around the world will suffering. So I think this is to say we should care because people are suffering now, but if you're not acting just now, I think we should care because in the future, either you or your offspring will suffer the consequences of this as well. This is, of course, in a status quo scenario. It's not something that we expect to happen if we make the changes that we need to make. Why should you care as well? This is a survey that is done by Ipsos, one of these large global survey companies, that goes out and asks people from around 25 countries, a couple of thousand people, who do you trust the most? The exact question, I can't remember what it was. I was supposed to write it down. But it's basically, look at the name of this profession or this person and tell me how much you trust them in a scale of 1 to 10. More or less, that's the question that they ask. Who pops up to the top? Year after year, it is physicians, doctors, clinicians, nurses, health professionals that are at the top. What's the second? Scientists. What's the third? Teachers. Some of you are all three at the same time. So why should you care? It's because you're trusted. Your message is listened to. Who's at the bottom? Politicians. Who is the loudest? Politicians. So we need to raise our voice because we're being listened at. Our voices are actually what move people to change. So gathering around this idea that our health depends on our environment and they're intrinsically linked is important, that we are trusted messengers, and we need to get that message out there. From working at the top to our policymakers to working with communities as well to create changes in how we how we board these challenges, how we tackle these challenges. So why should we care? Because we're trusted. A couple of last slides. Hope. If you haven't read Kate Raworth's book, I recommend that book. It's called Donut Economics, 7 Ways to Think Like a 21st Century Economist. It's not about economy per se, it's about a better future and what should be the guidelines of that better future. Now, this is called the donut in Donut Economics, and it basically states, and it brings together 2 basic ideas. One is the idea of the planetary boundaries, put together by the Stockholm Resilience Institute, and then the other is the idea that human rights should be universal, which has been around for the last 70 years, of course, or even from the French Revolution, some might say. So at the top, you see that outer green ring, that's the ecological ceiling, that's the planetary boundaries. It's the sound idea, it's a very sound idea, to say that there's only an amount of change that we can create before we risk our well-being. Right? There's only an amount of climate change we can cause before we risk our well-being, and beyond that amount, we should not surpass because we start risking our well-being. Similarly with air pollution, similarly with biodiversity, similarly with land, with fresh water, with nitrogen and phosphorus, with ocean acidification, there's a level we can support, and above that level, we risk our well-being. So that's what we call the ceiling. So we should only consume so much that we do not go above that ceiling. But we shouldn't consume so little that we don't meet the necessary needs of everyone around the world. And that's the inner circle, the social foundation. You see, it's like a house. One is the roof and the other is the floor. That social floor is represented there by human rights, right? The basic things like gender parity, political voice, quality income, nutrition, etc., right? And this idea in the middle is that if we manage to find that balance and we design policy to find this balance globally, right, not just at a country level, but globally, we can find this safe and just space for humanity. And this is what the idea of the donut is. This is already being applied at country levels. I just came back from Malaysia, where they're saying we're going to use this framework to guide our economic policies. There's cities already around the world, like Amsterdam, that are using these to design policies to guide the future of the city, right? How do we secure social foundation at the same time, respect planetary boundaries? And this is being applied around the world. You can read more about this work in the Donut website, which is there. Lastly, when we are learning about planetary health, then what is actually what you mean? What do I teach in planetary health when I say I direct a course in planetary health? I also teach in a master's in planetary health. What do we mean? We're looking at these 4 domains in this figure. One of them is what I just talked about quite a lot, which is how is the Anthropocene connected to health? What are those interconnections? But it also means, how do I understand this in the context of equity and social justice? How do you use system thinking and complexity to connect the ideas that are there? How do we create movements and also top-down change, not just bottom-up change, but top-down change? And how do we think this in a way that helps us change our value systems to reconnect with nature, right? Because at the core of our crisis, our multiple environmental crisis, is that crisis of disconnection with nature. If we were connected with nature to a point that we respect it, that we love it, that we appreciate it, that we cherish it, like our forefathers and mothers used to do, we would not be put in this pickle. Think of the way that you've become disconnected to nature. Think of the ways that technology has played a role there, how our food system plays a role there, how our religion even sometimes plays a role there. Think about all the ways that we have become disconnected with nature. And all that learning, right, these 5 domains of what we mean and what we teach when we talk about planetary health, is all kind of wrapped into these idea that this is happening at a planetary level, but learning also has to happen with local relevance. That is, how is this impacting my community, the people that I care about the most, so I can make it relevant and for people's different contexts. Because you're clinicians, I'm going to recommend this resource, and this is the last of the 2 last slides I'll show. This is called The Medicine for a Changing Planet. It's a collaboration from Stanford and University of Washington. It's a great case-based study resource database in which it goes through how are these different changes like toxic exposures, vector-borne diseases, pandemic preparedness, food security, climate disaster, eco-anxiety, extreme heat, air pollution. It goes through a very familiar to you clinicians' way of teaching in which we can understand how these things are connected, and it gives you further resources and literature. So I urge you, if you are wanting to learn more, to go to Medicine for a Changing Planet and learn more about this. Then, because some of you are students, I don't know if you know this, there's this thing called the Planetary Health Report Card, where people from within institutions can use the report card to grade, so to speak, how is my institution doing regarding planetary health. And I don't know if you know this, but Northwestern actually has one. The Feinberg School has already been evaluated. I want you to go to the website and see how you're all doing. So I'm not going to tell you how you're all doing. So I'm going to tease you there. If you want to learn more about the work of the Alliance, which is where I spend part of my time in DC, this is the website. There's many ways to engage at different levels, from being a campus ambassador to engaging in our conference, reading our newsletter, engaging in research circles, policy circles, education circles that we have. We have different communities of practice that we have created around different important themes. You can join as well the North American Hub. You can do a bunch of things. I urge you to go and learn more about our work. So I'll stop there. I think I overdid it by 7 minutes, but thank you so much, and I hope that was useful for you. And now questions.
Carlos, thank you so much. That was a terrific talk. So, as you sort of outlined, in public health and global health, we talk a lot about what are referred to the upstream influences on health, the larger social and structural determinants of health. It strikes me that both the potential and the challenge of planetary health as a framework is it's really taking our considerations of those upstream effects to a whole nother level. We're now considering potentially the entire life support system of ecosystems and our planet and how it's impacting human health and well-being in the short term and the long term. So with that being said, that requires then new stakeholders, as you were pointing up, new expertise being brought to the table in discussing all of this. In developing planetary health, how do we get there, and what are your thoughts on how we build both education and also a language that is going to bring this broad constituency together? And do you perhaps see, I don't know, the Sustainable Development Goals as at least a step in the right direction towards a nod to those issues?
That's a great question. I actually forgot to mention that this recent Consortium of Universities of Global Health Conference, we approved a new set of competencies that relate to planetary health. So if you are in the space of global health, now as part of your curriculum, you would have to learn about planetary health from a global health perspective. And we're trying to do that for nursing. We're trying to do that for medical students. We're trying to do that as well for public health education. So, and that kind of creates the foundation for people to be able to talk common language when it comes to common challenges. But of course, health professionals are only part of the equation. We need business people, we need engineers, we need people from the policy world to also be understanding that they have a role to play. And that is only through a common foundational language that we are saying planetary health has that capacity to be that common foundational language. I believe the SDGs did really pave the way to understanding that our health and well-being is interconnected. There's an SDG on oceans, there's an SDG on climate action, there's an SDG on food security that is connected to environmental challenges, there is SDGs related to cities, so it's laying out that. But what we see and what we are proposing is that some SDGs, there needs to be sort of a hierarchy to the SDGs in which we understand, and I think I really like the term that you use, that we use sometimes, which is there's life support systems, like our oceans, like our ecosystems, that need to be secured before we can start securing all the other things, right? So we need to have a degree of refocusing the importance of that. And the SDGs has done a really good job at that. Now, the post-SDG world is something that we're still struggling with. There's, in September, what we call the Summit of the Future, where kind of in New York, in the UN General Assembly, these decisions will be made. This is how the real world works. There's going to be a summit, people are going to be joining, and they're going to say what's going to happen after 2030, because we're coming up to it, and we still don't have a framework to guide development for the next 15, 20 years. We will be there, the planetary health community will be there, proposing planetary health as a joint framework to think about this. Obviously, this involves things like the donut and other frameworks that are out there. They're a permanent forum in indigenous ways of knowing. The full name I can't remember right now, but the Permanent Forum of Indigenous Issues will be there as well, proposing as well their way of looking at these interconnected challenges. And we are supporting them as well, and they're supporting us. So we're trying to build those coalitions in order to bring the agenda forward. And it's only through coalitions that we can do this. It won't be just one sector of society. But hopefully we'll get somewhere. So thank you for your question.
I was really struck by your drawing, sort of going back with the social determinants of health to our values and how important that is, and then connecting to where power lies, right? In this, these mental models that say that if I give you some, then I'm inherently losing, right? Like a zero-sum model, And so I was wondering if you could share, just to have some sparks of hope, some examples of people in power or countries where that mental model has turned around and where the values have changed, to understand that if we benefit those that are not in power, we'll benefit everyone.
Well, I can talk about boring things like taxes. Referring to Thomas Piketty's work here, I don't know if you've read Thomas Piketty. He's a French academician that looks at taxes and redistribution of wealth. And I think when we look at redistribution of wealth, that is one way that values are shifting in societies. Of course, that is not the case in the United States. I think the United States is the opposite of where we want to go when it comes down to redistribution of wealth. When I talk about values, is how values are, let's say, embedded in our economic system to allow to a point that people accumulate wealth to a really, really, really big, what's the word I'm looking at? It's not big, it's yucky, egregious, disgusting amounts, right? That is only allowed because values seep into our policy, that seep into our tax systems, that seep into how we redistribute wealth, that allows billionaires to exist. Right? That is what I mean, that values are the mother of the determinants, right? Because we value the fact that someone can own so much wealth, and we see that as a winner to a point that we elect them as president. Not me, but not people in this room, but you know what I mean, right? Because we are taught to value that's something important, something to thrive, something that is morally good. Then we create a system that allows that. Countries are making decisions to allow that, right? The distribution of wealth in different countries, let's say France has policies that don't allow intergenerational wealth distribution to be like that. So you can only inherit an amount of the wealth, not the whole wealth, and then the rest gets redistributed in the tax system. And other countries are making advance forwards in that. So that's Thomas Piketty's work, and he's looking at tax redistribution around the world through things like inheritance laws, et cetera, et cetera. So that's one way that values are showing up there. But values are showing up in other ways. For example, on how we decide to subsidize a series of things versus subsidizing another series of things. So when we subsidize things like fossil fuels and agro-industry, we're saying, it is more important to have people own their cars and have cheap fuel than people in the global south suffer the consequences for climate change. We're saying we, an individualistic society, are deciding that because my values say that I need to get from point A to point B whenever I want in my car, no matter how big it is, then that's values seeping in, again, into the policy realm, into the energy realm, into how we subsidize things like fossil fuel and car industries, right? Those are values feeding into that decision. Whereas you were to say, hey, no, I value much more things like equity and justice and climate justice and vulnerability of population in the global south, then we wouldn't be making those decisions, right? So this is what I mean, values seep into every decision that we make, starting from policy to individual. Of course, we need to take care of policy first if we really want to have structural change. So those are just some examples of that. And obviously, you said hope. I'm saying hope here. There are countries that are moving in the right direction. Of course, even China seems to be moving in the right direction at a pace that sometimes it's outlandish compared to other countries when it comes to, say, the energy transition, the transport revolution, and many other things. So we don't hear a lot about China in that sense, but China is actually that largest mover when it comes down to renewable energies in the world. There's no other country making that transition as China is doing at the pace that it's doing. So something good. Not just because of the size, because it's the capacity it has. So.
I'm going to follow it up with this question. So I'll give you a little bit of context and it'll explain my question. So I'm a pediatric infectious disease physician who work in Uganda on planetary health. So this has been like perfect lectures catered for my research. So thank you very much. And I do primarily pediatric HIV research, and I've become interested in how particulate matter affects the health of the children I care for. And we've shown that particulate matter independently is associated with complications such as their cardiovascular health. So it's not new. It's new in the sense of like the patient population, the setting that we're studying in. But now what, right? We know this is an issue. And so I've struggled a little bit with how to implement education and getting the stakeholders at the table, in the sense that the reason why air pollution is so bad in Kampala, Uganda, is because it's become industrialized. And when you speak to the Minister of Health, for example, you know, I get his point. It's his turn. It's Uganda's turn to kind of come out of this poverty, and they have new roads, they have a new airport, financed at a very high interest rate by the Chinese, but it's their turn. And so they're not really interested in learning about, you know, how to like not burn their rubbish or, you know, turn the cars off, like very simple things when you're idling. It's not where their priorities are at. And so my question for you, after I've told you my academic life story, is like, how do you convince these countries, and I don't want to make generalization for all global South countries, they can't control what US and Europe does, but how can they take action locally?
So this is a trick question. If I knew the answer, the world would be different, I would say. I mean, and I'm going to use maybe here analogies that might be simplistic, but when I think about countries like Uganda or other countries that are in that curve of real big economic growth, but are still reliant on fossil fuels, and you got things like a UNFCCC saying, United Nations climate change, let's say, panel, the COPs, saying like, hey, you got to reduce that. And they say, okay, I'll do it. Is anyone else doing it? Is the world actually doing the change that they need to do? And how are you, rich world that has already, you know, taken advantage of fossil fuels for much more than I, and your economy seems to be stable enough, and in part you are burning much more than me? Why are you asking me to make the biggest effort when you're not really doing it yourself? So an analogy could be like, yeah, why should I do it if my older brother isn't doing it, so to speak, right? And so that's part of it, right? They don't want to be the first movers, because the responsibility of being the first movers doesn't really have to be on them, right? And the world still can actually take carbon, right? There's still kind of a buffer we can take, but that buffer is almost exclusively should be used by these lower middle income economies, whereas the high income economies really need to turn down their use. So this is what we call the degrowth movement. I don't know if you've heard about the degrowth movement in the economic spheres. Degrowth basically says, higher income economies need to turn down the level at which they are using resources. Lower income economies will have, in a short period of time, to increase their use of resources in order to kind of get to a point where this inner circle of basic rights can be met, right? And they need to be helped by higher income countries to a point that they can do an energy transition really quickly, that they can secure the food of people very quickly. But that can only happen in a collaborative way, right? If there's no collaboration, countries like Uganda will never say, I'll be the first mover, because they'll look at the historical data and they'll say, who's contaminated the most? I have one graph here I want to show. I know you're probably, here's one graph. Wait, one graph I want to say. These are global CO2 emissions historically. So historically, who's put more carbon in the air? So you see USA there, right? And because of that carbon, we got to thank carbon because it's grown our well-being. This is Christiana Figueres, who used to be the executive secretary for the UNFCCC, also a Costa Rican, saying, we got to thank carbon because it's actually taken us a long way. So thank you, carbon, but no thank you anymore, okay? Thank you, but bye. US is rich, mostly because it's been good at using resources, so is China, so is the EU. But now it's the little countries' turn to try to grow their well-being, not their economy, grow their well-being, which is different. Right? They need to grow their well-being, and some of that growth will be supported by carbon emissions. But that will only be a fraction when it comes down to these other countries in the world. So there is some budgets that already have been made around who can burn how much. The US have already surpassed how much they can burn if it's going to be a fair share use of fossil fuels, which is going to be needed for the transition towards justice. So it's not like we're going to cut down CO2 emissions everywhere in the world, because that's not the reality that countries like Uganda can take right now. So it answers a little bit your country. I'm not completely sure what's the carbon budget for Uganda, but some of these numbers have already been calculated.
I think we're going to wrap the questions at this point. Please join me in thanking Carlos and Lisa for tremendously thoughtful and forward-looking talks today on promoting global health education. At this point, I'd invite everybody to our reception and the handing out of the many awards from the poster session.